John, from an anesthesia standpoint, I think Tracy is spot on, is obviously the importance of, again, we've talked over and over this, about this over the years, is the standardization. So there's two things, obviously, where anesthesia has a huge role, which is type of anesthesia, as well as intraoperative, perioperative, and postoperative analgesia. Can you comment on both those for us?
Right. I think, we get an opportunity to evaluate patients from all specialties, surgical specialties, and really even outpatient. Tracy did a really nice job of outlining the basic tenets, and we're talking about big operations, but we see the same problems even in outpatient surgery. So if we can apply these principles in all surgeries and decrease ileus or nausea and vomiting, that's how we measure in anesthesia, it's just postoperative nausea and vomiting, we can impact length of stay not only for inpatient, but also outpatient surgeries and increase throughput. So we do touch every phase of the surgical care. There are things we need to do preoperatively, and we need to do those in a standardized fashion based on what's best for the patient and the literature, not based on the fact that you and I trained in different places. So we try to apply standardization to the preoperative phase, the risk stratification, the intraoperative course, as Tracy mentioned, there's pain management there, as well as fluid therapy that we need to pay attention to. And then postoperatively, try to make sure that we reduce the use of narcotics as much as possible throughout. So different procedures require or are amenable to different regional techniques, but injections, subfascial catheters, which really takes collaboration between anesthesia and the surgeons, that has to be collaborative all the way through the process.
So touch base a little bit, John, about epidurals. Are there particular cases or particular specialties where epidurals, because again, there is obviously a cost associated with placing an epidural as well as the maintenance and use postoperatively. Do there tend to be certain procedures that show a clear benefit for the use of epidurals versus not using an epidural?
I think, you and I had experience early on a number of years back with epidurals for prostatectomies and so forth. And we clearly showed at that time that we decreased length of stay, but we were going from a couple of weeks down, cutting a couple of days off of it, and we thought we were really doing a good job. As it turns out, over the years, we found that the narcotics we were putting in the epidurals were actually causing ileus in some. Not as much as if we gave a big slug IV, but it was still causing some ileus. So we've gotten away from epidurals in most specialties. Probably the specialty we continue to do epidurals is in thoracic surgery. And we've gotten away from narcotics there as well. It's mostly just an infusion of local anesthetic, sometimes with very, very low concentrations of narcotic.
Sanjay, knowing your history and everything, so what about, are you seeing, and I think Declan mentioned this earlier, what about open versus laparoscopic versus robotic cases? Because I know you're very talented and well-versed in all. So.
Yeah, I think that when I was training, it was kind of the time that robotic surgery was getting big, so I had a little mix of open and robot, and I feel fortunate I got trained in both. And I now lean more towards the robotic approach, especially with cystectomies and doing intracorporeal urinary diversions. And, I think that from a pain standpoint, the pain is significantly less, the incisions are smaller, that's pretty apparent. I think the patients just overall functionally recover better. I think that extra time you spend in the OR doing it minimally invasively translates, I think, in the postoperative period to better recovery, less readmission. I certainly am seeing less wound-related complications. And, so I do think that contributes to it. But I think it's a multifactorial thing. It's one component of many things that are involved. I also do think that you do manipulate the bowel less. We do cystectomies and steep Trendelenburg, and I only really grasp the segment of bowel that I'm using. I'm not packing it back and forth and handling a lot. And that has been shown to potentially increase the ileus rate. It hasn't been studied super well. It's hard to study that. But I do think that all that matters. And I think those little incremental things translate down the road to just a quicker overall recovery.
It's interesting as we move into this arena of metrics, which obviously physicians have never been forced to do, right? I mean, you know, it's the standard joke. You can ask a surgeon who are the 3 best surgeons in his area. He doesn't mind. He can always name himself. He just can't think of the other 2. Yeah, right. So you know, we know that's always the case, as as we know. So we've talked about a number of things. We've talked about technique, robotic, lap, open. We've talked about, again, minimization of handling of the bowel, epidural versus, again, trying to decrease the use of really opioids. We've briefly touched about, which became popular was, gum chewing. Is there anything that that you can do preoperatively that's built into all of your protocols?
Yeah, and I think we started working on this. There's a big push for prehabilitation, and I think that once we got our basic framework for our ERAS pathway, we started really focusing on the earlier aspect of it, which is educating the patient, which I think has been the biggest thing that changes everything, is a patient knows exactly why they're supposed to do it, and I think that matters a lot. But also optimizing their nutrition. From patients I operate on for cystectomy, the median age is 70. They're smokers. They have a lot of comorbid conditions. And they're not the healthiest people right out of the gate from a surgical candidate standpoint. And so we try to we get them set up with a nutritionist. We're fortunate we have one floor below us, so just the logistics is easier. So they sign up for surgery. They meet the nutritionist, and they also meet a physical therapist to kind of get them in this prehab thing. And we're trying to work on finding out a way to assess how many steps they do or some activity pre-surgery, and we're trying to motivate them to get back to that level after surgery. And so I think all that education really helps. And we have really good physical therapists, and they always talk about how it's like Rocky, and they're going in for their big fight, and you got to get yourself ready for the big fight, which is the big surgery, which I think is very true. You got to optimize not just the physical aspect, but also the nutrition aspect.
I think that's a point well made, is that I think patients, do better. I think there's probably, I don't have any data to support this, but I bet that there's probably less litigation when patients when you match patients' expectations and outcomes, when they know exactly what, this is why we're doing things. If they have an understanding of that, as opposed to them just going blind and say, hey, sign the consent form, you're getting this operation, right? So, no, I think that's a great point, is this, what is it, prehabilitation?
Prehabilitation. Yeah.
I write a lot about it in educational materials, and I can't get my spell checker to leave that one alone yet. It's not a thing yet.
Yeah.